like, I think this is such an ideal topic in the point of the event, and, you know, thank you for inviting me, because I think that we've talked a lot about delivery of research, RCTs, but I think Johan has really set the scene that the patient really needs to be at the focus of clinical research and also clinical care, because we're really looking about wellness, quality, improving outcomes, but who's at the center of this? So I'm going to talk really about quality of life, but we know the WHO definition, which is a state of complete physical, mental, and social well-being. We know that. But health-related quality of life is seen very much, I think, within the research community, as we say in English, a cherry on the top of the cake. But I think that really quality of life and clinical outcomes relating to quality of life are the platter that the cake sits on. Without the patient being involved in treatment, our treatment is not successful. It isn't going to be as good as it should be, and it's crucial in terms of the insights into the outcomes affecting cancer patients. And I just wanted to sort of pull up some of the instruments, because we've had a huge growth in patient-reported outcome measures and health-related quality of life, and I've just pulled the quality of life instruments, partly from the EORTC. And I think as researchers, we're much more familiar with these ones down at the bottom, where there's good generalizability, but from a clinical perspective, they're not so strong in terms of specificity, in terms of what the values of the patient are. You need a lot of patients to actually make changes within these scores, and they're very generic. But there are now more sophisticated quality of life tools that are adaptable for clinical practice. You don't need like 100 items that you can actually use. You can adapt it to your context and clinical setting. But also there are very good symptom-specific tools to look at specific symptoms around fatigue or pain, or particularly around survivorship and palliative care. And these condition-specific ones are sort of coming in the middle, where we're looking at the trajectory of the cancer journey. But you can see the graph in the sense that specificity goes up in terms of quality of life measures, and then generalizability is at the bottom, where we've got normative data looking at controls and population level data, where we can look at the economics and compare to normal populations. So we've got a huge value in these tools. But health-related quality of life is about patient participation, not just in research, but it's in healthcare. It does improve precision of cancer studies, and if we're talking about the 4 Ps, it very much feeds into not only prediction, precision, but also patient involvement in their care. We know that if you monitor using quality of life instruments and look at health burden, you can actually determine the efficacy of therapies. But also we know that a lot of the self-rated measures are powerful predictors. So if you measure baseline quality of life, you can often predict morbidity from the cancer treatment, and it's a powerful predictor for many cancers. But also you can use it in terms of patient progression, and we know that it's a good screening tool for symptoms for things like emotional distress, but also in terms of support and communication. You know, for example, difficult symptoms, which in the clinic you might not want to ask about, sexual issues, if you can ask patients through a tool, you're more likely to get information. So we know that patient-reported outcomes, which are an element of health-related quality of life, are good for monitoring and quantifying clinical trials' adverse effects. But if you look at the reporting of FDA studies, only roughly about 40% of the data is actually ever reported. And if you look at the quality of life data that's reported, it's fairly poor in terms of taking items from the quality of life on specific symptoms rather than presenting or analyzing more the trajectory of quality of life change. So in terms of research, the thing that people don't always realize is there's a discordance in symptom recording. So if you ask Johan about his symptoms, they would be different from what a clinician would report. in terms of objective measures. Now, I don't know if you can see this, but this paper from Italy, where they looked at a whole range of clinical studies, it's published in ESMO Open, but what they found was a huge discrepancy between clinicians and patients in reporting of difficult symptoms. And if you look at anorexia, it's 80% discrepancy. So there's certain symptoms like fatigue, anorexia, constipation, diarrhea, fatigue, are symptoms where people are very there isn't a concordance between what is happening in the clinic and in what's reported in CTCAE. So what's happening is in trials, we're often underreporting adverse effects. Now, we've been talking about real-world data, and the Profiles study, which is from the Netherlands, you guys are doing great work in terms of with registry data. Van der Poel, France's team, have been using registry data to send out quality of life assessments to certain patient groups. And she's written a great paper looking at how it's influencing treatment and policy. But what you see is a much higher level of things like fatigue, persistent neuropathy, role functioning impairment. And if you look at population studies and you're looking at large numbers of patients, you're beginning to see that the risk factors emerging in terms of social deprivation, younger patients who are being treated at earlier stages, but also they're often associated with worse clinical outcomes. If you look at studies that are using registry data in other centres, you begin to see that you can begin to look at social inequalities. But also they often ask about clinical symptoms that are not really looked at in clinical trials. And cognitive dysfunction is one of the ones that is emerging, especially from the new immunotherapies and endocrine treatments. Things like azutamide causes cognitive function issues. So when you look at cognitive function, this is in a testicular cancer study, patients were still having problems years and years after they'd had their cancer treatment in terms of decision making and cognitively not as good as people comparable to their age. So these population studies are brilliant, especially when they're compared to normative data, because you can begin to see the effects of treatment. Why is this important? Well, for example, in gynecological cancer, only 41% of women go back to work after they've had cancer treatment because of the side effect profiles. So if we can do work with the quality of life data, you begin to see what are the things that really impact and which symptoms we should be really working on. This data is from the NHS, and every year the NHS sends a quality of life assessment electronically to cancer survivors. And this is in 190,000 patients who've had cancer treatment. And what you see here is the EQ5D comparison against cancer patients. So blue is cancer patients, orange is normal population for age matched. And what you see is that cancer patients have worse health problems than the age-matched population. They have more psychological issues and have more difficulty in terms of use of health services. But one of the things this survey does is it digs down to where they're treated regionally, and you can actually go into the database and the reporting of it and put in your clinical centre, and it will show you the comparison of your clinical centre compared to national data. So you can sort of deep dive into the data. Now, if you see on the right-hand side, this is social inequalities, and what you see is, this is for breast cancer, is that women who come from the poorest regions of the country have worse quality of life than women who come from the richest areas. And it's 20% difference. And that's significant for those women, and we need to ask why. The sadness with this is it's not linked to treatment data. So you can't begin to actually interrogate what are the differences from these regional areas in terms of radiotherapy, chemotherapy, and why these quality of life differences arise. And it is a sadness that this hasn't been linked at a registry level. This is sent out from registry data. but gives an indication that actually it's a good thing in terms of looking at treatment efficacy, but also in terms of those variability. So how do we increase the use of technology to collect and use health-related quality of life data? Well, the stuff that I've been talking about in terms of clinical trials, using PROMs, using health-related quality of life is what is called asynchronous, and also in terms of real-world data, which is you're asking patients for their feedback, but you don't give feedback to the patient. The hospital may give feedback, but the patient doesn't. But if you begin to look at synchronous use of quality of life data, which is where you're using the tools to actually inform your clinical practice, that you have symptom management and advice built into the systems, that you can risk stratify patients to know which patients need more support, maybe those with social inequalities or vulnerabilities or those at higher risk, you can then take a proactive approach to symptom management. Now, there's very good research in terms of looking at how this synchronous approach can improve clinical outcomes. So Ethan Bash has done amazing work from early 2016 looking at the use of patient-reported outcomes in advanced disease and symptom management. This is in the US. And he did the STAR RCT study in patients with advanced cancer. This is one center, the STAR, and he found that 7% fewer patients in the self-reporting arm visited emergency departments. They had improved quality of life. And if you look on the right-hand side, you can see a significant improvement in quality of life assessed at 6 months, 34% compared to 18% in terms of good quality of life. And this is with advanced disease. Now, if that was a drug, we'd be in there, you know, amazing. Red arrows. So he followed it up with a cluster randomized trial, and I think this is quite interesting, which is called the PROTECT, and this was published only, I think, last month. But what you find is there's no difference in survival when you roll it out to multiple centers in a whole region. You still have reduced emergency admissions and less visits to the hospital, but those in the patient-reported outcome group had better physical health, and they favored their symptoms, and they had better health-related quality of life. But it's almost this thing that when you begin to roll out clinical studies, the benefits are watered down because the symptom management is the critical element in terms of supporting patients. So that responsiveness to their symptoms is really critical. There have been successive studies in many countries across Europe, and Denmark are using PROMs a lot in clinical care. I've picked these two out as early runners, but recently in Brighton, they've been using PROMs as part of advanced disease following Ethan Bash's work, and it's on a system called My Clinical Outcomes. And I want to highlight this because what they have highlighted is the economic benefits, and I know we'll be talking about the health economics later, but it has a 1-to-4 benefit ratio. So for every £1 you spend on the technology and the collecting of that data gives you £4 back in terms of reduced service use, reduced length of stay, reduction of emergency admissions, improve symptom management. And what it does is it gives patients self-management advice and navigation advice on how to sort out problems, how to get information, how to get your support. And it advances the visibility of quality of life of data from patients. So when they come to clinic, you can see exactly what their symptom profile is completed at that time. Now, I know older patients often struggle with this sort of technology, but they have someone who helps patients complete the data. But mobile phones, smartphones are so in population these days that this is an advantage in terms of thinking about how we integrate quality of life tools and PROMs into healthcare, but also that it does have cost benefits. So finally, just to sort of pull this together, is that this is a meta-analysis of the studies that have been looking at integrating health-related quality of life. And what you can, if you can see this, it seems a long way away, but it favors the use of PROMs as part of routine clinical practice. And the effect size measured over time was 2.45 at 12 weeks. It diminishes over time and is stronger in patients who have more symptoms and advanced disease. So if you were looking at making an effectiveness change in your services, this is something that could have substantive benefits for patients, improving well-being, but also access. It improves communication. We know it streamlines consultations, improves the discussions that you can have with patients, because you can look at what they've written on their quality of life information, but also implementing it helps agree self-management strategies and actually harmonizes information across a region in terms of a comprehensive cancer centre. So there are lots of benefits. What are the issues? You need the technology to support it. You need money to actually implement it, and you need people to actually buy into it, to actually use the information, to actually use it as part of your assessment and clinical management. So just to round up, my key 3 points really are that health-related quality of life is not the cherry. It's fundamental to the cake. Without it, it would not be as good as it should be. We need to inform symptom management with asking patients directly, not using necessarily CTCAE. We should be using PROMs more effectively in monitoring. You can then triage patients more quickly and manage side effect profiles earlier. It can improve workflows, it can improve patients' engagement in care and adherence, and it expands self-management to being a fundamental of care. So it informs healthcare, not just from a patient perspective, but from a professional perspective. It also can help predict treatment outcomes so that national population level and real-world data can be used to look at adverse effects that may not have been picked up in clinical trials because you've actually maybe got more vulnerable patients in that population and much more realistic to the population you're normally treating. And then it can inform healthcare policy and services. And so I think it's something that is fundamental to future cancer care and should be part of comprehensive cancer centres. Thank you.